All right, in this one, we're going to do a basic approach to EKGs. So this is kind of geared towards the M1 student, but obviously any medical student who needs a refresher on EKGs. Of course, I can't cover everything, and my goal is to try to cover this in less than an hour, hopefully less than 45 minutes. So definitely not an all-encompassing lecture, but enough to kind of review the basics and then go over some really high-yield rhythms and how to identify those, and we'll talk a little bit about pathophysiology, but really just to help you guys kind of decipher the EKG. So we'll determine the following on an EKG: the rate, rhythm, axis. We'll recognize normal and abnormal P waves, PR interval, QRS, QT, T waves, and then some of the following EKG patterns we'll go over and a little bit more. So when we look at the EKG, right, there's a few major parts we need to be able to recognize. We have the P wave here, and the P wave is atrial depolarization. Okay, and then in between the P wave, so the P wave starts to where the P wave ends, right, and where the QRS picks up, that is what we call the PR interval. Okay, so here, this little divot here is the Q, and here's the R. So from the start of the P to that R wave, that is my PR interval. So here's the Q, here's the R, here's the S. Okay, and where that S wave picks up back to what we call our ISO baseline, right, our isometric baseline, which is really, if you were to kind of take like a straight edge and see kind of where is that baseline here. I like to look usually kind of before and after the P wave. That's really where my baseline is. Okay, that's going to come in important when we talk about ST segment elevation. But really, when that Q, we got the Q, the R, the S, when it gets back to baseline, that's where the QRS stops. Okay. And then after the QRS is your ventricular depolarization. And then after that, obviously, the ventricles need to repolarize. And so they repolarize, right? And they form what's called the T wave. So the T wave is ventricular repolarization. And then the U wave, not really shown here. Not really sure what causes the U wave. We do know it is associated with hypokalemia. They won't ask you like pathophysiology of that. You should be able to recognize in a patient with a U wave, you should check their potassium, and vice versa. If they have low potassium, you might see a U wave on an EKG. Remember, when my waves point up, that means the overall electrical activity is coming towards that lead. Okay, and when the waves point downwards, that means the electrical activity is going away from that lead. Okay, I have a picture of the leads coming up in a second. So how do we approach an EKG, right? I think it's 11 steps that I've outlined here for you guys, for you to use on an everyday basis, right? And the better you get at using these basic frameworks here, the quicker you are going to be at doing EKGs, right? EKG is a lifelong skill in medicine, and regardless of your field of medicine, you may be the only person in the room or around the hospital who can read an EKG, right? You can't always rely on the cardiologist. So first things we do, right? Determine the rate. So if it's regular, right? The R intervals, which I'll show you in a second, the R to R to R is coming at a regular beat, right? We can use the 300 rule. So all we do is we take 300 and we divide it by the number of the large boxes between the R waves. If it's an irregular rhythm, well, then you can't use that rule, right? Because R's are coming at random intervals. So we can't use the 300 divided by the number of big boxes in between R's. So I like to do the 10-second in a 10-second strip, which should be all of your EKGs. We just take the number of QRSs and we multiply that by 6. So let me reiterate it again, right? You look at your R to R intervals. If they're regular, we can do 300 divided by the number of large boxes between each R to R interval, right? And it will be the same because it's regular RR intervals. If they're irregular, like something like AFib, right, we take the number of QRSs in that whole rhythm strip, right, and we multiply it by 6. So I'm going to let you pause your screen, right? So for a lot of these EKGs, just pause your screen, and then I'll tell you, I'll give you my answer, right? But for this one, calculate the rate. Like, what is the heart rate, right? This is a classic question for an M1 exam. So pause, calculate the rate. So this rate's going to be about 85, right? If we go back, you can see, right, these R to R intervals, they're coming out at a regular interval. So I can use that nice 300 divided by the number of big boxes. I like to find where the R interval kind of really closely lines up to a large black line, right? So right here's a good one. And we got 1, 2, 3, 3.5, maybe a little bit more than a half. And so I just calculated it by dividing by 3.5 because that makes the calculation a little bit easier, which comes out to about 85. This is also normal sinus rhythm, which we'll define in a second. You should realize on your exams, right? You're not expected, like if you if you don't have a caliper, which, that's a story for another day, it's hard to get these rates, down to the exact value. So they'll probably, like, let's say they would give you on an exam, they would say, what's the rate? And they'd say like 60 to 70, 70 to 80, 80 to 90, 90 to 100, right? You would pick the 80 to 90, right? That's where this rate would fall probably into, right? Somewhere around there. Or they would give you wider ranges to make sure, no one, if you can calculate it pretty close, you could pick the right answer. All right. Okay, so now I want you to calculate the rate on this one, right? Pause your screen and think about it. So for this one, right away, you can take a look at the rhythm strip and you're like, this doesn't look the same as the last one, right? Look, the last one, boom, tacking out or going out at a regular interval here. And you look at this one, you're like, this is all over the place, right? We got a wide gap, short, 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 wider, wider, right? It's all over the place, right? And so I would call this irregular, irregular. And if you actually look at your rhythm strip, I don't see any discernible P waves, right? This is a tachycardia. It's irregular, irregular, and I don't see any discernible P waves. And we might have a little bit of fibrillation if we look really closely here, right? So this would be AFib, right? So now we have to do how do we calculate an irregular rhythm, its rate? We take the number of QRSs in that rhythm strip, we multiply by 6. So you see that, right? The heart rate would be about 132. So you take the number of QRSs in 10-second strip, multiply by 6. So 122, sorry, that should say 12 times 6, right? Or did I go 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22. It should have been 22. So I just added an extra one in front of there. So 22 times 6 is 132. So sorry about that, but holds the same. All right. So again, rate, regular R to R intervals, 300 divided by the number of big boxes in between the R to R intervals. If it's irregular, take the number of QRSs times 6. I cannot stress this enough. On your exam, right, on your M1 exam, especially if you're an MCW student watching this, your midterm exam, there will be at least one question, if not multiple. Just calculate the rate, right? Easy. Okay, easy points. So next, we got to determine the rhythm. So big question you ask yourself, right? Is it regular or irregular, right? Are the R's coming at a normal, consistent interval, or is it all over the place, right? And so how do we define sinus rhythm? Is there a P before every QRS? Is there a QRS after every P? And then we want to see the P waves that are upright in leads 1 and 2. And I'll kind of show you why in a second, right? So if it's not sinus rhythm, it could be a lot of things. The biggest ones for, your MCW exams, your USMLE step 1 exams, AFib, atrial flutter, and ventricular rhythms. So like wide QRS complexes. And I didn't really go into the wide complex QRS as much in this lecture, but that could be a story for another day. I could show you a picture as well. So again, P before every QRS, QRS after every P, and then other P's upright in leads 1 and 2. And so the P's being upright in leads 1 and 2 are important because here's my lead 1, here's my lead 2. So these are what we call our limb leads. And we see, right, our normal conduction of the heart, the SA node is somewhere up here, in the right atrium. And then it comes down to the AV node, it gets stuck for a second, goes to the His bundle through the left and the right bundle branch, depolarizes the ventricle, and then we start over again, right? So the signal is kind of coming down here from the upper right and moving down towards the heart, right? Towards the AV node, the bundle of His. So that's going to be moving in the direction of 1 and in the direction of 2. And remember, I told you at the beginning of this lecture, right? If we're going towards the leads, the peak will be up. It will be upright, right? Whereas if we're going away from the leads, the peak will be down, right? And so if you look at it, right, I didn't talk about this, but because it's more of an advanced concept, but AVR would be going away from the signal, right? The signal starting up here in the SA node, AV node, bundle of His, and then back, okay? And then starting over again. And so if you see, right, it's going towards 1, towards 2, but it's going away from AVR. So normally that P wave should be upside down. It should be upside down in AVR and then upright in 1 and 2. All right. So I want you to tell me, is this sinus rhythm or is this not sinus rhythm? So pause your screen and think about it. All right, so this would be an example of second degree AV block. And so this would be like a 2-to-1 conduction block. Now I'll talk about the conduction blocks all the way at the end of the lecture. But really what I see here is I look at my rhythm strip first, right? And I can see here's a P wave, here's a QRS, here's what looks like a T wave. And then here's another P wave, right? There's another beat after it. And some people might confuse that with a U wave, right? But this is definitely a P wave. It looks, if you see, right, it looks the same as this guy. That's how I can tell it's a P wave, right? And then we have a long pause. That's another thing that keys me in that this is a P wave that has a conduction block. If this were just a U wave without a conduction block, I should see my next P wave, somewhere in here. We shouldn't have this long pause. Okay, and then we go again. Here's another P wave, the QRS, the T wave, another P wave, not followed by a QRS, right? And then we start over again. Here's another P wave, the QRS. So if you look, here's a P, a P, 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 P. There's another P, another P, another P, another P, another P, another P, another P. And then here's the QRS, 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 QRS. And so clearly, if there's a P here and it's not followed by a QRS, and there's a P here not followed by a QRS, and a P here not followed by a QRS, and so on, this cannot be sinus rhythm. So in this case, right, we call it AV conduction block in 2-to-1 pattern. Okay, so it's a second degree AV block, 2-to-1 pattern. I'm not sure if you learned about like this, because this is kind of like a more advanced diagnosis, but it was just to illustrate the point that this is not sinus rhythm. Can you just identify this as not sinus rhythm? And then if we look, right, are the P waves upright in lead 2? Yes. Lead 1, it's kind of hard to tell, but yeah, I would call that kind of upright. You can see them for sure. And then AVR, even to illustrate the point, oops, look, there's the upside down P wave in AVR. So this is second degree AV block 2-to-1. P waves are upright in 1 and 2. So not sinus rhythm, spelled rhythm wrong. So then what do? We assess the axis, right? So we look at leads 1 and AVF, okay? So you probably learned like the thumb method, right? So I take my thumb, my left thumb is my lead 1. And so if lead 1 is pointing up, right? And then my right thumb is going to be AVF. And so if I look at the leads, and let's use our this one as an example, right? The EKG we just used, right? So lead 1, the QRS, the R wave is pointing strongly up, right? So I put my left thumb up. I look at AVF, and AVF is kind of hard to tell, right? Let's take this one looks pretty good here. So that R wave is pointing more up, right? So I would say both are relatively pointing up. And when I get like a tough one, like you see this one AVF, actually AVF starts here. So this one I would definitely consider upward, right? But let's say if we were a little concerned or we couldn't tell, we can use lead 2 as the tiebreaker, and lead 2 is clearly pointing up, right? So both are up. And when both point in the same axis, both point the same way, we call that normal axis, right? Okay, let's say we had an example where lead 1 was pointing up, but lead F, the R wave was definitely pointing down predominantly throughout the lead. So then I put my right thumb down and I put them together, right? And what are my thumbs doing, right? This thumb's pointing up, this thumb's pointing down. So my thumbs, they're leaving each other. They have left each other. So that's left axis deviation. And then the same idea, right? Let's say in lead 1, the R wave is pointing down predominantly. And in AVF, the R waves are all pointing up, right? So now my thumbs are coming right at each other, right? Right at each other, right axis deviation, okay? So we can have axis deviation in a lot of different things, right? For left ventricular hypertrophy, right ventricular hypertrophy, heart failure on either side, cor pulmonale causing right heart failure, right? Maybe you'll learn about that in your coming weeks, right? But again, it's all written in here, right? Both positive, normal axis, lead 1 positive, AVF negative, left axis deviation. And so I gave you some examples here. Lead 1 negative, AVF positive, right axis deviation. Gave you some examples there. If both are negative, it's called extreme axis deviation. You will not be given that for an MCW exam or for any, like, frankly, like USMLE step 1 exam or whatever med school you go to. That would be probably inappropriate for your level of training. So now I want you to calculate or come up with what is the axis here, right? So we've already gone over how to do rate, how to do rhythm. So you could practice that as well too. But what is the axis? All right. So we look at this, right? If we're looking at the axis, right? Lead 1 pointing up, and then we see lead AVF is pointing up. And hey, if we just wanted a tiebreaker, lead 2 definitely pointing up. That's normal axis. Now I didn't calculate this rhythm kind of off the cuff, but we can look at one that's kind of right on the line, and we got 1, 2, 3, 4. I would say, let's see, 1, 2, 3, 4. So whatever 300 divided by like 4.2, 4.3 is, that would be your rate. So we could calculate that really quick. So 300 divided by 4.3 So like about 70 beats per minute. And then do we look, right? Is there a P, 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 P always followed by a QRS? Absolutely. And then another P is upright in lead 2 and 1. And then are they down in AVR? Absolutely, right? So this would be normal sinus rhythm with a normal access at about 70 beats per minute. All right, try this one now. What is access in this one? So we see lead 1 is pointing up. Lead 2, or sorry, lead AVF. Look at the R waves here, right? The R waves are all really strongly pointing down. So we got here, and my thumbs have left each other. So this would be an example of left axis deviation, right? So lead 1 is up, but AVF and 2 are pointing predominantly downward, right? So even look at lead 2 as my tiebreaker, definitely pointing downward, right? So again, we've already talked about rate. If it's regular R to R intervals, 300 divided by the number of big boxes in between each R to R interval. Okay, so we take 300 divided by the number of big boxes in between each R to R interval. If it is irregular, we can do the number of QRS complexes by 6. Okay, we've talked about rhythm, right? So rhythm, we should have a P followed by a QRS preceded by a P. Okay, and then my P should be upright in lead 1 and 2, and they should be down in lead AVR, right? Now we talked about access, right? We look at leads 1 and AVF. They're both pointing up, right? The R waves are both pointing up. Normal access, if lead 1 is up, the lead AVF is strongly pointing down, right? Left axis deviation, my thumbs have left each other. If lead 1 is down and lead AVF is up, the thumbs are coming right at each other, right? So right axis deviation, all right? Then we check our intervals, okay? So now to check your intervals, right, you kind of have to know normal. I don't think they'll ever ask you the normal, but it's good things to know. The more times you look at an EKG, you can kind of just get the vibes of is this normal or not. But the PR interval should be 120 to 200 milliseconds. So what is that? That's 3 to 5 small little boxes, okay? Then we have, like if it's prolonged, we could think about first degree AV block. If they're short, the one you're going to want to know for your exams are Wolff Parkinson White. This LGL syndrome is more of an advanced concept. The QRS interval should be less than 120, right? So that would be less than 3 small boxes, okay? So that could be prolonged in ventricular rhythms or bundle branch block. And then the QT interval, right? 9 to 11 small boxes. I'm going to show you on an EKG a quicker way to look at them. Usually if the QT interval is less than half the distance between the R to R, you're pretty safe. It's a normal QT. And the one thing I want to say about the QRS interval, if the QRS is narrow, right? If it's less than 120 milliseconds or 3 small boxes, that tells me my heart is following the normal conduction pathway. SA node, AV node, bundle of His, ventricles, and start again. If my QRS is wide, what that tells me is somewhere else is starting the beat, right? We're not going down the normal pathway. So maybe it's starting from the ventricle, maybe it's starting from some random place up in the atria. Maybe it's starting at or below the level of the bundle of His. It's just not going in the normal pattern. And so by not going in the normal pattern, we're not following the really fast conduction to get that really nice ventricular depolarization. We're following kind of an aberrant pathway, right? And so that aberrant pathway is going to really slow things down, and that ventricular depolarization is going to be really slow, and you're going to get a nice wide QRS, okay? So I want you to kind of take a look at these intervals and tell me what do you see, and see if anything's abnormal here. So in this one, all the intervals are normal. Okay, so again, when I'm discerning my rhythm, okay, the best place to look for the rhythm is your rhythm strip, right? And the best place to look at most intervals is going to be your rhythm strip as well, because you get the full length, right? But you can look at every lead, okay? But if we look at this, right, again, I didn't calculate the rate, but if you see this one is not, first off, this looks pretty regular. And this one starts nice on a line. And we go 1, 2, 3, 4. All that lined up pretty good. So 300 divided by 4, right? Would be my rate just about here, right? Somewhere around in that ballpark. And then we look at what's my rhythm, right? Leads, we see a P before every QRS, a QRS after every P. We see the Ps are upright in lead 2. We see they're upright in lead 1. And then AVR, they're down. And then we can look at my access, right? Lead 1 is up. Here is lead AVF is up, so it's normal access, right? And then we look at my intervals, right? So remember, like 3 to 5 small boxes. So the PR interval starts a little bit after this nice solid line, and it clearly stops well before the next one. That's normal, right? And then I just kind of like check and make sure it's the same vibe going out throughout. Absolutely. Okay. I look at my QRS where we start and where we end back at the baseline, the isometric baseline point. Um, Definitely less than three big boxes, or sorry, three little boxes. And then my QT, right? So here's the start of the Q, and here's the T, and you have this. I see students get this wrong all the time. You have to go to where the T wave goes back to the baseline, right? You can't just like, it's not the top of the T wave, it's where it goes back to the baseline. So that would be about here. So from here to here, and yeah, you could count those little boxes, but this is clearly less than half this R wave to this R wave, right? Like, so half to half would be, oh, somewhere right in here, and we're definitely stopped well before that, right? So this QT would be normal, okay? Let's do the same thing here. So take a look at their intervals. I won't give you the full rate rhythm access. You guys are all pros at that now. So look at the intervals and tell me what you see. All right, so hopefully you paused your screen and thought about it. So this one, like if I'm looking at it right, looks pretty regular to me. I do see a P wave before every QRS, but there's something weird here, right? Look how wide, how long this P wave is, or how long the PR interval is, right? This is huge, right? So I think it's good to start here. This one lines up right on the line where it starts. And so if this were to be 3 to 5 little boxes, that QRS should pick up right here, right? So this, because one big box is 5 little boxes. So that QRS should pick up here if we're trying to keep the PR interval to 3 to 5 little boxes. But you see the QRS doesn't start to like halfway through the next big box. And if you look, it just keeps happening over and over and over again. So this is definitely a long PR interval. The QRSs look nice and narrow, so we are still following the normal conduction pathway. And then the T waves are right around normal, right? The T waves are pretty hard to see here. You can see the little fibrillation, but it's definitely stopping before halfway through the next one. Or halfway between R to R interval. So the T wave or the QT interval is within normal limits. The problem here is the long PR interval, right? And so when we have a long PR interval, and if I told you this patient was completely asymptomatic, you would diagnose first degree AV block, okay? So prolonged PR interval, maybe 35 milliseconds. The normal is 12 to 20 milliseconds or 3 to 5 small little boxes. So this is first degree AV block. Not a problem. We just watch the patients, all right? And then what do you think about this one? Okay, so take a look and tell me what you see. Pause it and tell me what's going on with the intervals here. So this is definitely a scary rhythm. What we see here is a wide QRS complex, right? These are all my QRSs. Look how wide this is right here. Let's see if we can find this one kind of starts right around the line, and you can see it's already the QRS kind of finishes way up here. That's way longer than 3 little boxes, right? I don't even need to count that. That's super wide. And so when we have a wide complex, right, and these are very tachycardic, right? These are coming off pretty rapid here. So when I have a wide complex tachycardia, right, this is more of an advanced concept. But when it's a wide complex tachycardia, you pretty much have two things. It's either ventricular tachyarrhythmia, right? So it's coming from the ventricles are starting this tachyarrhythmia, or you have what's called supraventricular tachycardia with a aberrancy. And all aberrancy means is you have a bundle branch block. Okay, these are very advanced concepts. So I really wouldn't expect you to know this. But here, this would be a great example of something that's likely ventricular tachycardia. Okay, we would have to do a little bit more investigation, but this is classically what ventricular tachycardia looks like. You don't really see any P waves, and in fact, if we look really carefully, we can actually see this little divot here, 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 and keeps going, right? And so this is what we call AV dissociation. So this is likely ventricular tachycardia, right? So I told you I wouldn't have a picture, and actually I forgot. So this is a great picture of likely ventricular tachyarrhythmia. We would have to do, again, a little bit more investigation, which is beyond the scope of step one. But this, at the very least, wide QRS tachycardia, okay? That you guys should be able to recognize. All right. So wide QRS. All right. And then I got one more, it looks like. So pause your screen and think about it. And tell me, tell me what's going on with the intervals here. And again, if you want to practice rate rhythm access too, you can do that. I'm just not try to keep this under under a time limit here. So it's not a super long video. I won't go over that for everyone. But this one, right, you see here's the P, right? First off, is it regular, right? Yeah, this looks pretty regular. You can calculate your rate as well if you wanted to. The P's are all followed by a QRS. The QRS are all preceded by a P. They're upright in 2. They're upright in 1. They're down in AVR, normal sinus rhythm. We're not tachycardic, not bradycardic. And then you see here, here's the P, right? Definitely within 3 to 5 little boxes. The QRSs all look nice and narrow, but there's something going on with this T wave, right? If you see where the Q starts and where the T ends, it doesn't get back to baseline until all the way over here, right? That's way further than 1/2 the RR interval, right? So a lot of students get it wrong. Again, we could even use this one. It's not like this little divot here. It's where the T wave gets back to baseline. And it really does not get back to baseline until it's like somewhere in here. So that's definitely a prolonged QT interval, right? The reason we care about prolonged QT intervals is because the ventricle is still repolarizing. And if we start a new beat, we have the chance of, we're kicking off way too many beats while the ventricle is trying to relax, that we're going to get into what's called ventricular fibrillation, or even torsades de pointe, right? Which I don't know if you guys have learned about that one yet. I don't have a picture of that one, because that's more of an advanced concept as well. But that would be what we call a paroxysmal ventricular tachycardia, right? Multifocal ventricular tachycardia, where we get kind of twisting of the points, right? So I would look up, if you have learned about torsades. I wasn't sure if you did. If you have learned about torsades, you can definitely look up a picture. It's pretty obvious when it's torsades. You get these Y complex tachycardias that look like they're literally twisting over the points. But we get worried about that. You guys have probably learned about several drugs that can prolong the QT. Whenever you see torsades de pointe, right, twisting of the points, Y complex tachycardia, polymorphic, okay, of many different, right? So it's polymorphic ventricular tachycardia. I think I said paroxysmal earlier. Sorry, that was a mistake on my part. It's polymorphic ventricular tachycardia. Polymorphic just means multiple different types. Whereas this guy, we would call this, if we decide, okay, this is ventricular tachycardia, we would call it monomorphic ventricular tachycardia, because they literally all look the same. And if you think about, okay, if you've seen torsades, or you go look up a picture, the waves look slightly different, right? The R waves going up and then down and up and down and up and down. So we call it polymorphic ventricular tachycardia. And so for those patients, we give IV magnesium. Even if their magnesium is normal, we give IV magnesium. That can usually do the trick. All right. So long QT here. All right. Boom. Let's keep it moving. So step 5, we examine the P waves. Okay. So we look at the shape and size. A tall and peaked P wave in lead 2 tells me we might have right atrial enlargement. A broad and notched, so it has 2 humps in lead 2, might be left atrial enlargement. And then obviously we've talked about the relation to the QRS. If the P waves are not followed by a QRS, we have an AV block, right? Because it's our atrials are not fully talking to the ventricles, right? We go SA node, firing on its own, boom, 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 goes to the AV node. The AV node holds it for a hot second, and then we conduct down the bundle, right? The bundle of His, down the bundle of branches to the ventricle. So if we have a P wave, that means SA node working fine. We're depolarizing the atria. But then if we're not followed by a QRS, there has to be a block at the AV node, right? If we're still getting a QRS at some point, right? There's some disconnect between the atria and the ventricles. And so what would that disconnect be? It would be the AV node, all right? So I have a nice picture for you here, right? If you go look back at, here's like a good example of, like, these look like nice, like small little P waves, beautiful. Look at this P pulmonale. Wow, look at how wide, or sorry, how tall and peaked that is, right? So usually we look at lead 2, you could get away with looking at lead 3 as well. But P pulmonale tells me we might have right atrial enlargement. And then you look at this guy, right? Look at these double humps, right? Normally we don't see that. That's called P mitrale. We might have left atrial enlargement. Now, the reason I'm saying we might, right, because we can't make these diagnoses based off of EKG. How would you make the diagnosis? How would you diagnose them with right atrial enlargement or left atrial enlargement? Think about it. Right, we do an echo, right? We do an echocardiogram and we figure out why. Why do they have left atrial enlargement? Why do they have right atrial enlargement, right? And we maybe would have to do more tests to figure it out, all right? So those are good ones to know. So then we evaluate the QRS complex, right? So I look at the width. We've already talked about this, right? If it's narrow, it's supraventricular, right? Again, I told you if it's narrow, we're following the normal conduction pathway, SA, AV, down the bundle of His, down the bundle of branches, depolarize the ventricle, and then repolarize. If it's wide, right, we're usually having a bundle branch block or a ventricular rhythm, right? So if we block one of the bundles, right, now we're going down. So if we have our left bundle branch and our right bundle branch, we get to the bundle of His, and let's say the left bundle is completely blocked for whatever reason, right? You had ischemia, and now the left bundle branch block or the left bundle is blocked. So now all we can do is from the bundle of His, we go down the right bundle of the bundle branch, and we depolarize that right side of the ventricle really easy. But then that electrical activity has to move all the way across the heart to depolarize the left ventricle. Whereas if this was a normal healthy patient, right, we go down both bundle branches at the same time, depolarize the ventricle at the same time, and then repolarize, right? You get a nice, quick, small, less than 3 little boxes of your QRS, right? But when one of the bundle branches are blocked, that the other side, perfectly fine, right? Depolarize is perfectly fine, but then it has to move all that electrical activity has to move all the way across the heart. And that's going to be slow, right? That's going to be a nice wide QRS. And you can often see those RSR prime patterns. Now, I chose not to kind of show pictures or discuss any further in this. You might have seen them here and there. I think it's a relatively lower yield concept for step one. I'm happy to make a video at another time just on bundle branch blocks if you want, and some of these other like lower yield kind of rhythm problems that we could talk about. I wanted this to kind of be as high yield as possible. Okay. Then we look at the amplitude, right? If we have high amplitude, we might have left ventricular hypertrophy. We might even have right ventricular hypertrophy. Left ventricular hypertrophy is going to be a really high yield one to recognize. And then low voltage, we might have an effusion around the heart, right? So if my leads, right, they sit on my chest and they pick up the electrical activity next to the heart, right? That the heart is literally shooting out, right? The problem is when you have an effusion around the heart, we now have a fluid layer in between my EKG lead and my heart. And so that can kind of depress the electrical signal that gets to the lead that gets shown on the EKG. So whenever I have a low voltage QRS, which I'll show you a picture of, there's a couple things that this could be. It could be an effusion. It could be that the patient is quite obese, right? Has a lot of tissue layers, right? And COPD is another classic cause, right? We'll talk about COPD and respiratory coming up, but in COPD, you often get hyperinflation of the lungs secondary to alveoli damage, right? And so they get these really barrel chests, right? That can mess with my signal capture as well. And then morphology, right? Certain delta waves, I'll show you a picture of those. Your RSR prime pattern in V1 could be a right bundle branch block, and then the broad notch R wave in V6 could be a left bundle branch block. Again, I don't want to go into the bundle branch blocks as much, but your V6 picks up the left side of my heart. The V1 picks up the right side of my heart. So if I see those bunny ears, right? So maybe you've seen the Anki card, or maybe you guys did briefly learn about it. If you see the bunny ears in V5, V6, we lean more towards left bundle branch block. If you see the bunny ears in V1, we lean more towards right bundle branch block. Okay, and I'll do a whole lecture on these at some point. All right, so I want you to tell me what's going on with the QRS here. So pause your screen and think about it. So in this one, we're going to have what's called left ventricular hypertrophy. So left ventricular hypertrophy, there's a lot of different ways to kind of recognize it. Okay, if you look here, I do have a P before every QRS, and maybe this PR interval is a little bit long if you actually look at it. So maybe we have a first degree AV block, but we definitely have a P before every QRS, a QRS after every P. The P waves are upright in 2 and 3. They're down in AVR, right? Lead 1 is up, lead AVF is up. So normal access. Although look at AVF, it's kind of like halfway. So, this patient might have eventually some left axis deviation, but again, we could use my lead 2 as the tiebreaker, and lead 2 is up. So I would lean more towards this being normal access. Okay. The QRSs look nice and narrow. Okay. But the problem here is when you look at leads V5 and V6, right, which pick up the left side of my heart, these are quite tall R waves. Okay. And there's a number of different criteria to diagnose left ventricular hypertrophy. The most commonly used, and the one that you'll probably get taught on wards and stuff, and in class, are called Sokolov-Lyon. Okay, so all we need to do is you take the height of the R wave in V5 or V6. You pick whichever one's taller. This one, V5, might be a little bit taller. So this is 1 big box, 2 big box, 3 big box, plus, maybe a half. So 3.5 big boxes. And so remember, each box is like 5. So 5, 10, 15. Oh, we'll call it like 17 and a half, maybe 18. Okay. Would be 18 milliseconds, right? Because remember, each little box is 1 millisecond. And then I take the S wave in V1 and I add those together. And right, so this is, 5, 10, 15, 20. It's a little bit more than 20. And so I add those together. And if that number is greater than 35, there's a pretty good chance you have LVH. It's the same idea as left atrial and right atrial enlargement. So remember, right atrial enlargement would be the tall P waves in lead 2. We call that P pulmonale. And left atrial enlargement would be the double humped P waves in lead 2. We call that P mitrale. It's the same idea as this. We don't make the diagnosis of left ventricular hypertrophy just off of an EKG, but it can surely tell us, hey, we should maybe get an echo and look for left ventricular hypertrophy. So again, Sokolov line is probably going to be the most useful one for you guys to know. You just look at V5 and V6. You look at the R wave. Whichever one's taller, you pick that one. And then you look at the S wave, the down S wave in V1, and you take that number and you add it to the number of in V5 or V6, right? The number of milliseconds. And if it's greater than 35, it's a good chance of left ventricular hypertrophy. Oftentimes on like a USMLE exam, they'll make it super obvious. The lead, like the R waves in V5 will literally like go off the page, okay? And the S waves in like V1 will like come all the way down to like V3. And you're like, what the heck's going on? Right? When it's like that obvious, right? Like when it's that high, it's obvious. It's left ventricular hypertrophy. Some of the most like the most common cause of left ventricular hypertrophy, hypertension, right? And aortic stenosis, right, would be a common cause as well. So this is left ventricular hypertrophy. So I just put it in Word for Sokolov line criteria. You take the R wave in V5 or V6, whichever is taller. You add that to the S wave in V1. So if it's greater than 35 millimeters, there's left ventricular hypertrophy. We confirm with an echo. Okay. So then we look for the ST segment changes, right? So again, the definition of STEMI is actually quite complex. For the sake of being an M1 and a USMLE step 1, I just think about like a 1 millimeter elevation in contiguous leads. So V2, V3, or lead 2, lead 3, things like that, right? That go in succession. Would suggest an acute myocardial infarction and STEMI. Depression, you either have horizontal or downsloping, could key me in on ischemia, and then if diffuse concave elevation could be pericarditis, right? So remember, in like acute myocardial infarction and STEMI, we've had a plaque rupture that has now cut off complete blood supply to some part of the heart, right? Some artery, some part of the heart. So we get transmural infarction. For a NSTEMI, right, we're gotten like partial block of the subendocardium, right? And so we're getting there, right? If we don't treat this patient, relatively soon, we have the potential of having an acute myocardial infarction. These patients will have ischemia of the heart, and they will have elevation of their troponins, right, which are a sensitive marker of that get released from dead cardiomyocytes, right? But the problem is they don't get released like right away, right? Sometimes it takes a while. So oftentimes, if a patient comes in with chest pain, you don't just get one EKG and one set of troponins. You get serial EKGs and serial troponins, and you see how things change if you have a concern. And then pericarditis, right? I'm going to show you what ST segment changes look like on a STEMI. They look like tombstones most of the time, okay? Like nice tombstones, okay? Whereas pericarditis tends to be concave. They turn the other way, and I'll show you a picture. And they tend in pericarditis, they tend to be more diffuse, right? So it would be like odd if like you had ST elevations in like almost all your leads, like that would be, you'd have to have blockages in so many different arteries, like that would be very odd. Okay. So I want you to just like look at the ST segments here and kind of tell me what you see. And so hopefully you picked up, there's some arrows in here, right? This was the only like good one I could find. But there are arrows where you can see the elevation of 2, 3, and AVF. So which artery is blocked here? Which part of my heart is going to be impacted? So 2, 3, and AVF control, tell me the inferior portion of my heart, right? So the inferior wall of my heart is infarcted, right? In this case, we have ST segment elevation. So it's a transmural infarct, and the for most patients, the inferior wall is supplied by the right coronary artery, right? And then you got to think about, okay, what else does the right coronary artery supply? It also can supply, in most patients, the SA node and the AV node, right? So in these patients, you might also see relative bradycardia, right? And then if you think about it, the right ventricle is extremely preload dependent, right? The right ventricle needs to stretch, and then remember, it's a pretty weak side of the heart, so it needs a lot of stretch in order to contract against the pulmonary vascular resistance. So if your right ventricle is no longer being supplied a lot of blood, okay, and we're stopping like some of the blood flow to the SA and AV node, right? This patient may have a pretty low blood pressure and a pretty low heart rate, right? So it's kind of an odd presentation. This comes more into play when you talk about like management for step two, which I'm not going to cover here, but it's things to consider. So again, yeah, sorry, I didn't see on the first time I pasted this and I didn't even see the arrows on here. So sorry if that gave it away, but it's a good example of recognizing the ST segment elevations. And I kind of I'll go back to I'll go all the way back here. This portion right here that I'm highlighting with my mouse, this is what we call the J point. So the J point is what I use to define if the ST segment is elevated, right? Because ST segment, it starts, right where the S wave begins and where the T wave ends. And we use this J point when the J point is elevated or down or depressed, right? That's what we use. We compare it to the baseline, right? Boom and boom, my baseline. We compare it to the baseline to see if it's elevated or depressed, okay? So let me get back to where we were. And so you can see here, right here, around here is the J point, clearly more than 1 millimeter above, clearly more than 1 millimeter above. Same here, same here. So I want you to look for that J point, okay? All right. And here's like a nice, you probably have seen this, but your inferior leads 2, 3 AVF, the right coronary artery, and or in a very small majority of patients, the left circumflex. And then lateral leads 1 AVL, V5, V6 would be left circumflex or your diagonal of your left anterior descending artery. And then your anterior septal leads V1 through V4, your left anterior descending artery, right? These are super high yield. Please, please, please go into your exam on Monday or whenever you guys are taking exams and USMLE step one, knowing these. So 2, 3 AVF, inferior wall, right coronary artery or left circumflex, right? More commonly, right coronary artery. 1 AVL, V5, V6 would be my lateral portion of my heart, right? So that would be left circumflex or diagonal of the LAD. And then the anterior septal would be V1, V4, and that would be my LAD. Right. So this is an example of, your concave up ST segment elevation. So you see how these make a nice scoop here. And I like to call them saddle ST elevations, right? And so you can imagine like if you were riding a pony, like this would literally be your saddle you would sit on. So I remember it as like the pericarditis pony, right? So I see nice ST segment elevations, and oftentimes with pericarditis, due to the effusion, it also throws off the PR interval. And so we can see depressed PR segments or PR intervals and elevated concave ST segments. And remember, in pericarditis, it tends to be more diffuse ST segment elevation, right? So again, when you look at, okay, like it would be really odd if I had, like, when you look at where these EKG leads are, it'd be really odd if I had ST segment elevation 1 AVL, V5, V6, and 2, 3 AVF, right? That would be you'd have to have multiple clots in multiple spots or multiple plaque ruptures, which would be pretty odd to happen at the same time, right? So usually when I start seeing diffuse ST segment elevations, especially if they're concave up, and if the patient like meets the clinical history, right? So pericarditis, right? Pleuritic chest pain, it feels worse lying down, feels better leaning forward, right? They could have a cough. You start thinking about other, right, recent upper respiratory tract infection, inflammatory diseases, like all of my systemic collagen diseases, lupus, scleroderma, even RA, can potentially predispose. If a patient has a cancer, it can lead to pericarditis as well. So all malignant pericardial effusions. So all things to consider, right? Okay, so what's happening in this patient? So hopefully you paused your screen and kind of thought about what's going on here. When I look at these voltage, right, they look really small, okay? And actually, right, so like, especially like this one, it's like every other voltage looks pretty small in my my leads here, or my rhythm strip. And so really, if you look here, this one looks kind of tall, small, tall, small, tall, small, tall, small. When you see this pattern where you get like one that's like normal height or tall, and then a small one, we call that electrical alternates. Okay. Um, so that tells me that there might be an effusion around the heart, and the heart is swinging through that effusion. So when you have a nice effusion that surrounds the heart, such as in cardiac tamponade, okay, um, what happens is the heart, it'll beat and it'll kind of swing in the effusion one way, and then when it gets really close to the effusion, it leads to a low voltage QRS, right? I already kind of explained that we have fluid that's kind of blocking the EKG signal from picking it up from the heart. Okay, it's blocking the EKG lead from picking up that electrical activity. But then the heart kind of swings back the other way, and now you pick up a normal QRS, right? So it goes, it's based on the heart swinging through this effusion. When it gets really close to the effusion, it's hard to pick up that signal. When it swings away from the effusion, it's easier to pick up the normal QRS. And then low voltage, right? That could be effusion, it could be obesity, COPD, amongst other things. When I see electrical alternons plus low voltage QRS, that kind of keys me in on cardiac tamponade. And I'm not sure where you guys are at kind of in your education, but tamponade would be an effusion that has now cut off forward blood supply, right? So my diastolic pressures in all four of my compartments of my heart, right? My left atrium, left ventricle, right atrium, right ventricle, the diastolic pressures have equalized, right? So there's no more forward flow. Oftentimes we might see what's called Beck's triad. So Beck's triad would be hypotension, elevated JVD, and then muffled heart sound, secondary to the effusion around the heart, the massive effusion around the heart. And so in this patient, right, the JVD is because there's a lack of forward flow, so the flow moves backwards. They're hypotensive because there's a lack of forward flow. We can't perfuse the body. And then the muffled heart sounds is because of that effusion, right? So treatment for this, you stick a needle in their chest and you drain that fluid. It's called a pericardiocentesis. Okay. Obviously, we would not make the diagnosis of pericardial tamponade or cardiac tamponade based off of an EKG, but it can certainly help, right? The definitive diagnosis would be an echo. Okay, so low voltage, right, would be defined as less than a half millivolt in the limb leads, or 1 millivolt in the precordial leads, and then the electrical alternons, low voltage QRS followed by normal QRS, right? So taken together in the right clinical context, it is concerning for cardiac tamponade. Usually tamponade happens after you have pericardial effusion or pericarditis. It can, maybe you don't know enough about the patient, right? Maybe the patient just presents to the ED and you have no idea. So you got to be on the lookout for it. So think about that Beck's triad, and then the low voltage QRS plus electrical alternates. Okay, so then we inspect the T waves. So inversions can be normal in AVR and V1, but if they're in any other leads, we think about ischemia, hypertrophy, or even problems in the CNS. And then peak T waves could key me in on hyperkalemia, and flattened T waves could be in hypokalemia. So again, in AVR and V1, an inverted T wave is okay. In other leads, right, especially if they're contiguous, we start thinking about ischemia, hypertrophy, or CNS events. And then when you get the nice tall peak T waves, that look like if you were to like stick your finger on it, it would hurt like it's a needle. We think about hyperkalemia as usually the most common cause there. So take a look at this EKG, pause your screen and tell me what you see. So in this one, right, especially in like V3, V4, those look like nice tall peak T waves. If I put my finger on it or if I took a seat on it, that would really hurt. So I'm pretty concerned for hyperkalemia here. So these are peak T waves, check their potassium. We will talk in my lecture at some point how to lower your potassium levels. I have a whole lecture in my YouTube channel already if you guys are curious, or if you've kind of learned about it. But managing hyperkalemia is a pretty important topic. I will not go into it now, right? They're story for another day. So go watch that YouTube video or come email me or we'll talk about it another time. Step 10, you examine for U waves, okay? They're seen best in V2 and V4. Again, it can happen in various different reasons. The one you want to know for USMLE step 1 is hypokalemia. So if you take a look here, right, V2 through V4 are the best places to see them. And you can see, right, I think honestly, like V4 would probably be the best. Here's my QRS, here's my T wave, and then here's another little fibrillation, right? That's something. It doesn't look quite the same as the P, right, in most cases. So that is what we call a U wave, right? Um, so it's not right. You see how like wide this U wave is compared to the P that normally precedes every QRS. That's how I can kind of tell, it's not another P wave. It's nice and wide. There's something going on here. So that is what I would consider a U wave. I would definitely want to check this patient's potassium, right? And then we correlate with clinical findings, right? Oftentimes, you will have some sort of history on this patient. Every now and then, you know nothing about the patient, or someone just hands you a stack of EKGs and says evaluate. Um, but for the sake of USMLE exams and your in-house exams, you'll have a vignette. So chest pain plus ST elevation, it's likely a STEMI. Palpitations plus an irregular rhythm, it's likely AFib. Okay. Um, so I'm just going to run through them real quick again, but you determine your rate, um, you determine your rhythm, you then assess your access. Okay. You check your intervals, you examine your P waves, you examine your QRS, you look for ST segment changes, you inspect the T waves, you look for U waves, and then you put it all together, right? And so really, if you think about it, there's a nice pattern to this. Rate, rhythm, access, boom, do those first. And then you just go in order, right? Look at your P waves, look at your QRS, look at your intervals, look at your T waves, look at your ST segments, look at your U waves, right? You can honestly, like, this is the way I go through them. If you have a different way that works for you, go ahead and do it. The big thing I'm pointing out though is you need to be systematic about it, right? Every EKG should be read in the same way. Okay. So I practiced this enough times that like I know exactly where I'm looking. My eyes guide me. I know the key is you guys will see this when you get to like chest x-rays and stuff like that, and other findings. Your gut is always going to want to tell you to like go towards like the crazy finding. If you do that, you might miss another thing that would have helped you in the diagnosis, or could change your diagnosis. So keeping a systemic pattern is really going to help you. Okay. And then, yeah, let me just for the sake of it, rate, right? Three, if the R to R intervals are normal, 300 divided by the number of big boxes. And then if they're irregular, you take the QRS number, the number of QRSs times 6. Okay. Rhythm, right? Are the R to R's intervals consistent, or are they not, right? So regular versus irregular. And then is it sinus, right? Are there a P before every QRS, a QRS after every P? And then are the P's upright in 1 and 2? And are they down in ABR? Okay. Um, let's see here. The axis, right? If they're both up in 1 and ABF, right? Normal axis is 1 is up, ABF is down, right? They've left each other, left axis deviation. If 1 is down and ABF is up, they're coming right at each other, right axis deviation. All right. Intervals, right? The PR interval should be 3 to 5 small little boxes, or 120 to 200 milliseconds. The QRS should be less than 120 milliseconds, or 3 small boxes. And the QT interval should be 9 to 11 small boxes. Or when the T comes back down to baseline, if you start from the beginning of the Q wave to where the T comes down to the baseline, that T coming down to baseline should be less than half the distance between R to R. Okay. All right. Keep it moving. The P waves, right? Look at the size. We've already talked. A P should be followed by QRS. And then if they're tall and peaked and lead to right atrial enlargement, if they're broad and notch and lead to left atrial enlargement. So this would be P pulmonale in the right atrial, and P mitrale in the left atrium. Okay. Evaluate the QRS, right? If it's narrow, it's a supraventricular arrhythmia, right? The arrhythmia is starting from above the AV node. Okay, if it's wide, it tells me it's a bundle branch block, or potentially a ventricular arrhythmia, or potentially a supraventricular arrhythmia with an aberrancy, right? A block in the bundles. And with regards to that, right, if it's a wide QRS, all you got to tell yourself is, we're not going down the normal conduction pathway of SA node, AV node, bundle of His, down the bundle branches, depolarize the ventricle, and then repolarize. We're not going down that pathway. Okay. We can look at the amplitude of the QRS and we can see left ventricular hypertrophy, or we could see via high voltage, or we could see low voltage, which could tell me maybe effusion, obesity, COPD. And we can see different morphologies of the QRS as well. We can look for ST segment elevations, right? So for the sake of M1, think about 1 millimeter elevation in contiguous leads could suggest a STEMI. If they're horizontal or downsloping ST segments, it could be ischemia, right? And remember, we look at the J point and we compare it to the baseline, right? And I like looking at the baseline in between the PR interval and kind of preceding the P. And then if you have diffuse concave elevation, think about pericarditis. Um, Okay, and then we talked about lateral leads, 1 AVL, V5, V6, inferior leads, 2, 3 AVF, anterior septal leads, V1 through V4. Very important. Inspect your T waves, right? They're normal to be inverted in AVR and V1. If they're inverted in other leads, think about ischemia, hypertrophy, or CNS problems. If they're peaked, think about hyperkalemia. Okay, and then we look for U waves, right? The U waves will look different than P waves, so don't get them confused. They're seen best in V2 and V4. It could key me in on hypokalemia. And then we put everything together. All right, we've got a few more for us to practice that you'll pause your screen and you'll think about. So take a look at this, pause your screen, think about what is going on in this patient. So this, we're going to get more into like rhythms. You can calculate the rate and access as well. All right. So this would be totally normal sinus rhythm at a rate of 85 with normal access, where we could do our pattern here. But there's a P before every QRS, a QRS after every P. I look in one, I look in lead two, and the P waves are up, right? Even up in lead three. And then they're down in lead AVR. Okay, normal sinus rhythm. What's happening here? Pause your screen, think about it. Okay, so this is definitely AFib, right? Irregular. I'm not seeing any discernible P waves. And in between, right, I get these nice fibrillation waves, right? This is AFib, right? Remember, AFib usually occurs from a ectopic foci at the pulmonary veins that just kind of kicks off, right? AFib just kind of does this, and we shoot through. So AFib, right? Really, I want you to understand the pathophysiology of it coming from the pulmonary veins. I think that's all I'll say about AFib because I don't want to get into treatment here as much, right? But really in general, right, rate versus rhythm control, they've proven to be relatively about the same. Normally we shoot for rate control first, so something like metoprolol or a dilitazam or verapamil, okay, and then not sure if you guys have learned about Chad's VAS scores. If you've never heard of that, not going to be on your exam, but Chad's VAS score is something we use to decide is the patient going to be, should we put them on anticoagulation or not? That is what I'll say about AFib. I won't go into cardioversion or catheter ablation too much. All right, next one. What do we got going on here? All right, so this is definitely rapid. I don't know if I calculated the rate looks about like 150. Like it looks like it's just about like two boxes in between. It's very fast, right? It's clearly tachycardic. We could take the time and kind of map them out. But yeah, this one looks pretty good. So one big box, a little bit more. Yeah, I would say right around 150. Is this regular? Yeah, it's absolutely regular. And then it's hard to see the P waves here. So really, it looks like the P waves actually, if you look really closely, are kind of buried behind the QRS. And so that's classic for AVNRT, right? So when I have a narrow complex tachycardia, there's a number of things it could be, right? There's five big things it could be. It could be AFib. Okay, we've already just seen AFib. Does this look like AFib? No. It could be atrial flutter. I'm going to show you a picture of atrial flutter. This does not look like atrial flutter. It could be AVNRT, which I'm going to teach you the pathophysiology about really quick here, or it could be AVRT. Okay, so AVNRT is AV nodal reentry tachycardia, and AVRT is atrioventricular reentry tachycardia, right? So AVNRT involves the AV node, AVRT does not. Okay, and then the last cause could be like a multifocal atrial tachycardia, which I doubt you learned about in M1 year. But that's when we have a multiple abnormal foci. So we get multiple different formations of the P wave. Okay. But when I see narrow complex supraventricular or narrow complex tachycardia with the retrograde P wave, that keys me in on it's likely AVNRT. So the rate here is about 150, and maybe there's some right axis deviation. Not the purpose of this. This is kind of what I wanted to talk about. So in a lot of people, we have just one pathway in the AV node, but in some people, we have multiple pathways. So there's the fast and the slow pathway. The fast pathway repolarizes really slow. So things move down the pathway really fast, but going back up really slow. Things move down the slow pathway really fast, and they can repolarize or sorry, they move down the slow. Oops. Let me just start over. So in this, right, the fast pathway, we go down fast, but we repolarize really slow. And in the slow pathway, we go down slow and we come back up fast. Okay. Um, so oftentimes if we have just one beat going, totally fine. The problem is if you kind of like take a look at the pictures, when we have a premature atrial contraction, right? So that would be kind of indicated here. We have an abnormal beat, right? So we have just gone down our normal fast pathway, boom, boom, and that fast pathway is really slow to repolarize. The thing that happens though that can lead to this AVNRT is if we have an abnormal beat coming from the atria, right? This slow pathway is really fast to recover. So we get an abnormal beat while the fast pathway is still recovering. This abnormal beat can go down the slow pathway, and by the time we get to the bottom, right, and to then go conduct to the bundle of His and the bundle branches, this fast pathway has repolarized and we can go back up it and we'll just go around in a circle, a circle, a circle. So I kind of wrote that here. When a premature atrial contraction arrives at the AV node, the fast pathway is still in the refractory period, so the signal travels down the slow pathway. By the time the signal reaches the end of the slow pathway, the fast pathway has recovered. The signal then travels retrograde up the fast pathway and then back down the slow pathway, creating a reentrant loop. So literally what I just said. But if you like seeing it in words. So again, I kind of talked about that. You might not have visible P waves, or you could see them retrograde, right? Because the atria and the ventricles are contracting at the same time, right? And so if they contract at the same time, the QRS, the ventricle contraction is a much stronger contraction. So it's going to kind of mask the P wave, or if anything, we might see a P wave slightly after the QRS, okay? So again, in some patients, we might have two pathways. We go down the fast pathway. It's really slow to repolarize. But then if we get a premature atrial contraction, we get an abnormal foci from somewhere that kicks off a beat. We can go down the slow pathway. And by the time we reach the bundle branch, right, or the bundle of His, we can come back up the fast pathway because it's kind of gone through its abnormal phase. It's gone through its delayed phase, right? Its repolarization is done. And so we can go back up through it, and then we get a re-entrant loop that we just go, 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 go. All right. And then so what do you see on this one? What's abnormal here? So pause your screen and tell me what's going on. All right, in this one, I see it's kind of like a almost classic EKG, right? It will be a classic EKG. We see an upstroking, an upsloping of the QRS, and we see a really short PR interval. So when we have a short PR interval with an upstroking, this upsloping QRS, we call that a delta wave. The combination of the two is concerning for Wolff-Parkinson-White syndrome. Short PRS or PR, wide QRS, and a delta wave, right? So for this one, right, the normal route is signal for the atria to beat. The AV node delays the signal, and then the ventricles beat, right? SA, AV node, down through the bundle of His, through the pathways to the ventricle. In Wolff-Parkinson-White, we have an abnormal accessory pathway. Now, this is happening outside the AV node, but it's the same concept, right? Things just go in a loop over and over and over again. We're just outside the AV node. This abnormal pathway tends to be what's called the bundle of Kent. So in this case, here's the SA node. It kind of goes to the AV node, and we can go down the bundle of His towards a normal pathway. But the SA node can also send signals down through this bundle of Kent that can then reactivate the ventricles, right? So there's no delay, right? Only the AV node holds electrical conduction for a hot second, okay? This abnormal accessory pathway can just let as many electrical foci through as possible, okay? So we're beating through SA node to AV node. This pauses. We go through the bundle of His, through the bundle branches, but at the same time, we're shooting off an electrical signal through this accessory pathway, right? And then we're going and exciting the ventricles way too early, right? And so we can get a tachycardia. And you can see we go kind of in a loop over and over and over again. This would be an AVRT, all right? Okay, next one. What do you see here? Pause your screen and think about it. All right, and this one, hopefully you caught, right? Potentially, I'm not seeing really any abnormalities in the rate or the rhythm. What I am seeing are nice ST elevations. Here's my J point, my J point, my J point. Man, these are elevated in V1, V2, and V3. So this would be what we call an anterior acute myocardial infarction. So it's in the anterior lead, so it's likely impacting your left anterior descending artery. Okay, next one. What do we got here? All right. So these, look at my atrial contraction, right? My ventricular contractions are coming off, this actually almost might be bradycardic, right? But look at how fast the atria are contracting, right? And these are my classic sawtooth pattern, right? They'll probably make it pretty obvious on in an exam, right? It's just these classic sawtooth pattern because the atria are contracting so fast in atrial flutter, right? So this classically occurs from an ectopic foci around the tricuspid annulus, and it's the same idea as AFib, right? We're just kind of overexciting the ventricles and overexciting the atria and then overexciting the ventricles over and over and over again. So we get rapid ventricular contraction. If our AV node is still intact, we will stop some of these beats. And so we can hopefully slow ventricular contraction, but the atrial contraction is going to be wild, right? Look how fast these are going. Okay, and it's the classic sawtooth as this thing re-entrance around the tricuspid annulus. All right, so be able to recognize that one. And then I just kind of showed you examples of AFib, right? Irregular, no P waves, atrial flutter. We got the nice sawtooth, and then multifocal atrial tachycardia. Look at how this P wave looks different than this one, looks different than this one, looks different than that one. So we got multiple P waves. That's classically seen in COPD, amongst other things. All right, almost done. This is kind of what I was talking about before, right? In SVT, 5 main things. Atrial fibrillation, pretty easy to tell, right? Atrial flutter, pretty easy to tell. AVNRT, right? Don't worry about this stuff. This stuff is pretty advanced. AVNRT would be your supraventricular tachycardia, usually with retrograde P waves. And again, that's when you have 2 pathways in the AV node, right? So your fast pathway that repolarizes slow and your slow pathway that repolarizes fast. We get an abnormal premature atrial complex that goes down the slow pathway, and we meet it where the fast pathway is repolarized. So we just go back through and we go boom, 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 over and over and over again. AVRT, the classic examples, Wolff, Parkinson, White, where we have the short PR and then the wide QRS with the upstroking called the delta wave, right? So that's our classic there. You have your bundle of Kent where the SA node is going down through the AV node electrical conduction, but also through this accessory pathway that doesn't have any delay. So we're really rapidly contracting the ventricles, okay? And then you have your atrial multifocal tachycardia, right? Which we didn't really talk about as much. And then I think last but not least, we have our conduction blocks. We've kind of mentioned them, right? First degree, right? Your PR interval is a little bit longer, right? It's longer than 3 to 5 small boxes, okay? But this is totally not a problem, okay? It's asymptomatic. We just watched, okay? In second degree, right? This is an example of 2 to 1, but in second degree type 1, right? There's 2 types of second degree. There's second degree type 1, where you get a longer and longer prolongation of your PR interval, right? So the PR interval, if you look at it, it gets a little bit longer, a little bit longer, a little bit longer until you eventually drop a beat, okay? And then in second degree type 2, right, the PR interval is normal, and then you drop, right? And it doesn't have to be like a set, right? It's not, I said normal, drop, right? It kind of depends on the patient, right? But you have a normal PR interval, a normal PR interval, and it's just always normal until out of the blue you drop a beat, okay? And so you have a P, but there's no QRS that follows it. Whereas in second degree type 1, right, we have a prolongation of the PR interval to the point that we then drop a beat, okay? And then in third degree AV block, right, my Ps are all talking to each other. My QRSs are all talking to each other. So my atria are talking to each other. My ventricles are talking to each other, but they're not talking amongst each other, right? The atria do not talk to the ventricles. So if you actually map it out, right, the P waves come at a normal interval and the QRSs come at a normal interval, but there is no relationship between them, right? There's multiple P waves here without any QRSs to follow. And so this one, right, I'm going back to like the second degree too. If you look, right, so like this is a normal PR interval, there's my T wave, and then there's a P with nothing following it, right? The 2 to 1 block is kind of hard to determine. What is it? Is it second degree type 1 or second degree type 2? Because I don't have enough beats to see if this PR interval would actually get long enough. Because after the first like normal beat, we lose the QRS, right? We get the conduction block. But just go look up a picture. I'm sorry I don't have it in here. Look up a picture of second degree type 1 versus second degree type 2. Sorry, I kind of put this in a little bit too fast and didn't realize that. But I have pictures. If you guys are MCW students, I have pictures in my 180 slide cardiac PowerPoint that I sent you guys. All right, to finish it, because I'm a little bit over the time I wanted to. Last questions, right? So things you want to think about, right? When you're thinking about the rate, is it normal, fast, or slow? When you're thinking about the rhythm, is it rhythm regular? Are the P waves present? P before every QRS, QRS after every P, right? Are the P's upright in 1 and 2? Are they down in AVR? Axis, is it normal, left, or right deviation? Intervals, look at your PR, your QRS, your QT interval, your P waves, right? We already kind of talked about, are they normal in morphology and size? QRS, is it narrow or wide? Is there evidence of hypertrophy, low voltage, right? Are there bundle branch blocks, ST segments? Are there elevations or depressions? T waves, are they inverted, peaked, or flattened? And then U waves, are they present? All right, that was definitely a lot. I hope this helped. For some of the ones that we kind of talked about, but I didn't have great pictures of, things like torsades, things like you can even throw ventricular tachycardia. I showed you a picture, but that would be a good one to go over. And then like your second degree type 1, second degree type 2 AV blocks would probably be good ones. Again, I'm sorry I didn't have great pictures on those. We talked about them. So hopefully that helps. And you can recognize them. If you have any questions on this, please email me. I'm around. So I can definitely help. Let me know. All right. Hopefully it helps.